Good evening. Thanks
Yeah.
to the AIOC Scientific Committee 2021 for the kind invitation to share my personal perspective on the not so well told story of thyroid eye disease. I acknowledge all my teachers, my mentors, my colleagues from whom I've learned a lot from in terms of both diagnosis and management of thyroid eye disease, and compliments to my colleagues here at NUH, where we first started our multidisciplinary clinic way back in 2004. Apart from the standard disclosures, I'd like to acknowledge that I organized my first ever thyroid eye disease symposium in 2001. That's 20 years ago. And I'd like to compliment Dr. Milind Nayak and Dr. Suryasnath Rath for a beautiful compilation of surgical management of thyroid eye disease, which encompasses a lot of modern techniques itself. Also bring you greetings from our NUH UGOGO team, the first team outside of Europe to become an official member of UGOGO, which comprises not just ophthalmologists, but endocrinologists and immunologists as well. If you read about the history of thyroid eye disease, most of the major contributions in the Western literature is from the 18th century. However, is Bodhidharma, who is supposed to have hailed from the south of India, the founder of Zen Buddhism and Kung Fu, who was described to have the first thyroid eye disease, and subsequently in the 11th century, a description from the Middle East. If you look at the natural history of thyroid eye disease, Felix Rundle described the concept of the Rundle's curve, where there's a concept of activity which was subsequently figured out, where interventions is supposed to make a difference, especially medical interventions. And this is something where we have learned from our immunologists about early active intervention with the Rundle's curve in thyroid eye disease. And the rationale here is, although it was described only in the 40s, with the advent of steroids, initially oral steroids, and subsequently in the 70s from the IV methylprednisolone, which was shown to be much highly effective with less toxicity and less recurrences, initially started for renal transplantation. That has transformed the way we manage thyroid eye disease now. So the knowns in thyroid eye disease are, number one, the females have almost a 10-fold preponderance over males. Most majority of the cases are the mild disease, but the moderate to severe disease and sight-threatening disease, even if it comprises 5 to 15%, can take a big toll. Association of smoking is now well known, the charms, harms. First line treatment is well known, is now pulsed IV methylprednisolone, not oral corticosteroids. The morbidity of moderate to severe disease is being well recognized now. And the surgical management of thyroid eye disease, which starts off with orbital decompression, including navigation technology, for apical orbital decompressions and tailored decompression, followed by strabismus surgery, eyelid retraction repair, and blepharoplasty. Pathogenesis has been beautifully described over the decades. We now know the important contributions of the interleukins, the IGF-1s, where the role of these on the orbital fibroblasts, which predisposes to the adipocyte formation or myofibroblast formation, depending on which patient has which preponderance of which pathogenesis, results either in proptosis or in fibrosis with diplopia itself. The not so well known are the gender distribution kind of changes with moderate to severe disease, with the male predominance is slowly creeping up, and to sight-threatening disease, where the ratio now from 10:1 changes to 1.4:1. The pathogenesis in the individual patient is still not known, and hence there's still a role for shotgun treatment with IV methylprednisolone with or without radiation. What are the trigger factors we are less aware of, and what is the second line of management? In the past, it used to be methotrexate and cyclosporin, azathioprine. That is changing a little bit. The role of radiation and role of regional steroids, including orbital steroids, is making a comeback. And finally, whether you can combine procedures. Also, what is least known is the toll it takes on the individual and the family in terms of anxiety, depression, and even suicide. And what is really unknown is the genetics of thyroid eye disease, the concept of silent active disease, which is predominantly seen in Asians but can be seen in the Western population, management of persistent active disease, what we call as PAD, and management of refractory disease, where you've thrown it against a disease, whatever you've had, what do you do next? The psychosocial burden on the family and community, and finally, high suicidal tendencies in some of these patients. So these are examples of silent active disease where the classic symptoms of rubor, callus, tumor, dollar is gone, but patients have new onset disease and may be labeled as inactive when they're really active, including patient in the bottom below who's got a compressive optic neuropathy, who was ignored because she had no RAPD, but she had bilateral symmetrical optic neuropathy. Persistent active disease is other terminology which I think is very important, because when you adopt a standard treatment protocol based on whichever guideline you follow, when you have persistent inflammation, what do you do then? That's where the second line management comes in with the modern UGOGO 2021 protocol. So what are the risk factors for severe disease? It's very important that the older the patient they are at presentation, the more severe disease they're going to likely to have. Males at diagnosis, whether they are smokers or non-smokers, are also at much higher risk. Severe and prolonged hyperthyroidism, hence working in multidisciplinary teams, getting your thyroid dysfunction under control is very important. Monitoring and your TRAB and TSI levels are very important. Avoiding indiscriminate treatment with iodine 131 for persistent hyperthyroidism and patients who have various forms of trigger factors, which include stress. So in terms of management, there are essentially 4 questions you need to answer. First, is most important is whether it is or it is not really thyroid eye disease. Once confirmed, whether it's an active or inactive disease. Third, what is the severity of the disease? And finally, very importantly, what is the quality of life? It is important to take home message that the diagnosis of thyroid eye disease is clinical, clinical, clinical. There are patients who are suspected to have thyroid eye disease, but just because they had normal thyroid function tests or not so elevated thyroid antibodies, or the CT scan was done and the muscle size was normal, were ruled out to have thyroid eye disease, but did have indeed thyroid eye disease. Here's an example of a patient who had proptosis of lid retraction, thought to be diagnosed and managed as thyroid eye disease, but indeed has high myopia. The second important thing is whether it's active or inactive disease. That's where we resort to the clinical activity score or the inflammatory index, where early intervention with intravenous methylprednisolone based on the quality of life transforms and restores them more to a normal quality of life. And it's important to realize that people said most of the diseases are mild, why treated proactively? And this is a patient who really follows a Ruddle's curve and has progressive disease from unilateral proptosis, lid retraction, to strabismus and disabling diplopia and keratopathy, where proactive treatment should have made a big difference. The third question is the severity of Thai disease, from mild to moderate to severe and sight-threatening disease. And these are examples of patients who have either severe exposure keratopathy or compressive optic neuropathy. And in our book, even disabling diplopia and primary field of gaze come under the severity, where you need to do early intervention. The fourth question you need to ask when you diagnose and manage these patients is, what is the effect on the patient's individual quality of life? There are 2 major scores, the GOQOL scores and the TEDQOL scores, which is a much faster form, which needs to be assessed, which defines the threshold for intervention. Even if so, the new 2021 guidelines say that even if you have mild disease, as long as it's active based on the quality of life, you can resort to various forms of intervention. So what's really new with thyroid eye disease? We are defining lower and lower thresholds for intervention, typically based on the QOL. Early referrals is very important, and typically referral to a multidisciplinary thyroid eye clinics where there are experts managing them, not just from the ophthalmological point of view, but from endocrinological point of view and immunological point of view. The 2016 UGOGO protocol is out, and what is coming in is 2021 protocol. We'll touch a little bit about it, yet to be published. And finally, the role of targeted therapy, namely teprotumumab. So these are now new guidelines where we are defining interventions for mild disease based on the quality of life, to moderate disease, when what is really new is incorporation of mycophenolate sodium along with IV methylprednisolone based on a 6-week plus 6-week protocol. And once it becomes inactive disease, you can observe and manage. Versus if you have persistent active disease, you can either resort to the intravenous methylprednisolone again, which we don't do, but we resort to one of the other immunomodulatory agents. Orbital steroid radiotherapy is considered when systemic immunosuppression is contraindicated. Teprotumumab is holding a huge promise, but the cost is going to be a deterrent. Rituximab and tocilizumab may also be considered, but however, evidence is more based on case reports rather than anything else. And for severe sight-threatening thyroid eye disease, after initial immunosuppression with intravenous methylprednisolone, you can resort to various forms of decompression. And finally, in the era of targeted therapy, teprotumumab is holding a lot of promise. It's an IGF-1 receptor antibody, where it's supposed to show up to 90% response, even in later stages of disease, even in chronic disease, may show some promise, not just in proptosis reduction, but also strabismus and compressive optic neuropathy. But the cost may be forbidding until it's going to be available worldwide. So in summary, thyroid eye disease, in my personal opinion, is a common, yet uncommon in an average ophthalmologist practice because it's commonly misdiagnosed and mismanaged. We believe strongly in early referrals to dedicated multidisciplinary team where proactive intervention, medical intervention in the early stages with biologics when indicated, and customized treatment to the individual patient, be it medical treatment, surgical treatment, and rehabilitation. And finally, most importantly, emotional psychological support lifelong for these patients are very important. And thank you once again for the kind invitation, and happy to take any questions based on the panelists' expert experience. Thank you very much.